Great, great. Yes, I can. Thank you so much. And it's really an honor for me to be asked to be on this call. You all are doing such fantastic work in Canada. So I'm going to be talking about the work that we've been doing south of the border. So you obviously can go to the next slide, which just states that I have no commercial relationships to disclose. I always comment that it would be nice if I did, because then we would have more funding to do the work, and I know we were talking about that before. So the presentation overview, we're going to a little bit talk about some of the evidence on transition planning impacts and the gaps in evidence. This is from a review that we did with a medical student. It was published this year. And then look at some of the conceptual frameworks for transition measurement that for us down here include the 6 core elements, and then talk a little bit about the options for measuring that we've been using over the past a year or two with the new core elements. Next slide. So many of you already know this, but a lot of people ask, what is the evidence for transition planning impacts? And clearly, there's a lot out there. They're usually disease-specific, as you can see in diabetes, cerebral palsy, spina bifida, HIV, and so forth. But there is sort of enough evidence to begin to think about how you can go ahead and plan. And the next slide shows you some of the gaps that a lot of the studies are small numbers. They focus really on single chronic conditions and very few in developmental disabilities. They're based on usually one site, an adult sites. It's very pediatric focused. The interventions are very diverse. And the measures used to evaluate transition are very widely variable and tend to really focus on care in general, not looking at transition specifically. And then studies use before and after design, but often lack a comparison group. Next slide. So you can keep clicking here and put in the rest of this slide. So what did we do back in 2010 in the United States? The large associations, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians got together, put representatives forward with families and youth and other representatives, and came up with a clinical report, which is sort of like a clinical guideline, but not quite in that format. And it, instead of just targeting youth with special needs, it targets all youth. And with looking at the literature, we felt we should target at age 12. It's an algorithmic structure. If you haven't seen this report, it really is set up that way to be thinking about putting this into an electronic record system, and extends through transfer into adult health care. So it's really bringing in the adult half of this. Next slide really goes on to say we're working about putting transition into preventive and chronic care visits. The algorithm was translated into these 6 core elements, because everybody said this is wonderful. You don't want to put it up on a shelf. You've got to think of a way to have practice improvement, and this effort was funded by the Bureau of Maternal and Child Health. And there is evidence that we went on to build around these 6 core elements. We did healthcare learning collaboratives, both in primary and subspecialty care, between 2010 and 2012 in Washington, D.C., Boston, Denver, New Hampshire, and Minnesota and Wisconsin. So it's quite broad. I ran the D.C. Learning Collaborative in both rural and urban settings. We use the Learning Collaborative methodology from the National Initiative for Children's Healthcare Quality and pioneered by the Institute of Healthcare Improvement. This is the Plan, Do, Study Act and getting together, and this whole process is a lot of evaluation. There were charters and so forth about how we were going to evaluate this. We also developed an index after the Medical Home Index that we evaluated the process with. And the bottom line here is we demonstrated that these 6 core elements and tools were feasible to use in the clinical setting and resulted in quality improvements in the transition process within the practices. And you can look at that article if you want to from the Journal of Adolescent Health this year. From that, we then did a Plan, Do, Study Act. We went back to all the learning collaboratives and said what were the problems with the 6 core elements. Then from there, we went out to about 100 transition experts and had them relook at the new core elements, and that's what you're looking at today. Next slide. So here they are, and how they sort of connect with the age ranges that where the core elements are. So there's a transition policy, tracking, readiness, planning, transfer of care, and transfer completion. You can see how it's sort of that wavy figure and how it sort of fits together with the ages, particularly around preventive care or chronic care visits. Next slide. There are lots of tools. This is just to give you a sense of how many there are. Next slide. And what did we do with the new? There are now 3 distinct packages that are available on .transition.org. These are all customizable. They're in Spanish, the tools are, and the tools are at reading grade levels of 5.7. You can see they vary according to what the young person is doing. So if they're going to be transitioning to an adult provider, that really can apply to pediatric family medicine or med-peds providers, whether they're nurses or physicians or anybody. If you're going to be transitioning to an adult approach to care but staying with the same provider, you can see that's the middle piece. And then integrating into a young adult into adult health care, that really is focused on internal medicine and family medicine and med-peds who will be taking in these young adults into their practices. Next slide, please. So let's run through them quickly so you just have the background. Many of you may know this already, and I know you have great different tools in what you've been working in, but just so you know the background of how we looked at the evaluation. So the policy, I want you to know, is the most important one that all the families and young adults and youth say, this is it. If I had to vote for any of them, this is the crucial one, because they really want to know transparency about what the process is and when they have to go. A big issue in the United States is many of the young adults feel they were sort of kicked out and left, and there was no planning process that went on. So the key part of these policies that were developed by all the learning collaboratives and many of the group that we're talking with now, is that you have to talk a little bit about when this process will start. Something happened to the slides, but when the process will start, and also what will happen at age 18, including the options for supported decision-making, and clarify the support of what you're going to offer in this. I don't see the slides anymore, but I would go to the next slide. I'm looking at transition from pediatric to adult health care, your original opening.
Interesting. Do others see the slides? Could you just send me a quick chat or something in the... Do you see them now?
Aha. So you're absolutely, you got it. Tracking and monitoring. They're there. Thank you so much. So tracking and monitoring, it's really to support the practice of the system, to focus when they're beginning this process for a pilot population. And there are lots of options up on our website. You can do it by paper, or you can put it into an EMR. You can see there's an individual transition flow sheet for use. We're really showing you a lot of the tools on the pediatric side. Next slide. And then transition readiness. What's expected on the pediatric practice and what's expected on the adult practice side. Obviously, readiness assessment, locating adult practices and providers who are interested in collaborating and receiving. That was something that we had no difficulty with in our learning collaboratives, despite much of the discussion of pediatric providers that they couldn't find them. I think when we offered what was going to be available to them through this learning collaborative, they were very interested in doing it. And the adult practices then went back and said, who wants to see young adults in their practices? For instance, our internal medicine practice is 125 providers in the general internal medicine. 5 were interested to start. Now many more are interested. And they had to share their policy and their welcome letters and so forth. So the next slide really shows you the readiness assessment that we have put up generically. It is customizable. So this is not evidence-based except for the first two questions. These are validated questions that have been used in many settings in motivational interviewing, and everybody finds these absolutely key as a part of this, which is how important is it for you to prepare for the change, and how confident are you? And this has been used whether you're doing work in obesity or anything, that if you're scoring low, you've got a lot of work to do to get somebody to get to that ready to change moment. And the feedback here, youth and families really appreciated learning what the skills ought to be. The providers felt strongly that some had used other ones that you could score, but they found that the score didn't help them really decide they were ready. So many of them appreciated just having this as a discussion tool. Next slide. This is just showing you the suggested welcome letter and the FAQs. This was the young adults got together. We have about 30 of them that advise us across the country, and they suggested these are the top questions that in that welcome letter should be made available. Next slide. Transition planning, this just shows you a part of this is a plan of care template that really focuses on their overall priorities and how health can support that. There's a combined medical summary and emergency care plan, which is given to the youth in this process. And this is the template there is sort of combined the American Academy of Pediatrics and the American College of Physicians template. There's a recommendation to put this information in cell phones. And outside the unlock component, there are things that you can download from to be able to do this. Offer a condition fact sheet and some of these very unusual illnesses, that the conditions that adults are not familiar with, to try and offer that. We have an example of one with the spina bifida from the Spina Bifida Association up on our website. And it was really important. The adults really appreciated the pediatric providers offering to be consultants during this transition process. Next slide. Now, this is transfer of care. This is evidence itself, a little bit about what should be available, a transfer letter with the information that's stated there. I think it's really important that the pediatric practice state clearly that they'll cover the youth until they actually are seen by the adult provider, so they aren't lost in this no man's land. Next slide. And the same thing occurs on the adult side. You can see the kinds of things that are recommended that they should be thinking about and discussing on the adults on these first couple of visits. We know that landing, i.e., I always make transition like a flight. You're going down a runway, you take off, that's the pediatric side. It is bumpy no matter what you do. And then you land on the adult side, and there's a runway down there. And when you talk to pilots, the most important component is that landing. And so we're focusing on trying to make sure that adult provider can make that connection and engage the youth and needs all the support they can get from the pediatric side so that they will then follow up. And I think that's the crucial moment. Next slide. Then there is the transfer completion, and this is one of the evaluation tools that comes up here. It's really a sample healthcare transitions feedback tool. These are questions that come from the National Survey of Children's Health in the U.S. and the new ADAPT AHRQ survey on transition for 16 and 17-year-olds. Next slide. Now, when you're thinking about measurements, the way we looked at it, this process and outcome impact components. Under process, what are the activities necessary for practices to implement to demonstrate transition performance? And then outcome impact, what transition activities are associated? And we really have taken the lead from the Triple AIM framework in the U.S. What's the patient experience, better quality, and reduced health expenditures? Next. So other considerations whenever we're talking to our national providers, the things that you should be thinking about is really what's the purpose, writing a kind of charter when we're working with teams or working with systems. Who are they going to look at? What are the practices that are going to participate? What does it look like? What are the interventions? Almost all of them are coming to us as they would have the 6 core elements and do them in a very standard way and have a time frame that they have outlined and who are the stakeholders involved. And we try to get payers involved in this process when we're starting this. Next slide. So what are the options for measuring them that we've been looking at? So we're thinking about experience of care, population health, and cost of care. In the experience of care, it's the youth, young adult, parent experience, and obviously provider experience. Population health is around self-skills, autonomy, and the process of transition care, and the cost of care. So next slide. So on measuring experience, we talked a little bit about the feedback survey, and then we've done key informant interviews or focus groups with youth and young adults and parents in many of these learning collaboratives, and key informant interviews of pediatric adult providers. We did that for sure to redo the 6 core elements. Next. Around options for measuring sort of the quality improvement process, there are 2 that are available that we have developed on our website. The next slide shows you one of them, I think. This is an initial healthcare transition assessment. It's a qualitative self-assessment tool modeled after the Healthcare Transition Index. It provides a snapshot of where the practice is in transition process activities. It has questions on consumer feedback and leadership. It really shows an optimal activity for each score. So in a sense, when people look at level, I'll show you level 1 to 4, they get a sense of what the goalpost is around each core element. And many, actually almost all of the major healthcare delivery systems have utilized this as a baseline to really jumpstart this QI effort, to show everybody a little bit about what it should look like. Next slide will show you an example. For example, for core element 1, transition policy, you can see here level 1 is clinicians vary in their approach to healthcare transition, including appropriate age. Everybody's sort of doing their own thing. And then level 4, but they have a written transition policy approach here that's developed with families and includes privacy and consent, a description of the practice supports, and then actually gives it out to everybody involved. So you're giving it out to all 12-year-olds or all 14-year-olds, so everybody is aware and knows what the process is. And this is true for each of the core elements. Next. This just shows you the component around youth and family feedback and youth and family leadership. The practice has no formal process to obtain feedback versus the practice involves youth in developing or reviewing the transition process that's going on. Next. The other is a much more formal measurement tool. It's an objective scoring method. Our national NCQA asked us to develop this. It measures the implementation of these 6 core elements, including consumer feedback and leadership and dissemination. It's really intended if you're going to start a very formal quality improvement process. Next. This gives you an example, for instance, on transition policy. You either do or do not do these statements. It has the possible documentation, and you get a score. This all adds up to 100. You can see I didn't do the other 6 core elements, but you can see youth and family leadership, and each one of these happens around each of the core elements. Either they're involved or not. And then there's a question around dissemination. If you're only looking at asthmatics in your practice, and that's 10%, you'd only score 1. But if you're implementing it across the system for all youth in the transition age range, then you'd get a much higher score. Next. This is just what proportion of youth. A lot of people use this sort of the ages entering the program and the number that complete this. We use these kind of tools when we were integrating the 6 core element into our Medicaid managed care program in the District of Columbia. Next. So measuring the cost of care. So in the United States, we have some real issues for youth, the young adults 18 to 24-year-olds, They are, interestingly enough, less healthy than the 12 to 17 or 26 to 30-year-olds, and they use the emergency room more than any other group under the age of 75 in the United States. So getting the data about the use of ER, hospital care, whether they're fulfilling their medications. We've got a lot of this data, for instance, from our DC managed care, and we found that those with developmental disabilities, 40% had seen their pediatrician in the last 2 years. This is the 18 to 21-year-olds, and more than 60% had used the emergency room twice in the past year. So getting that kind of data, looking at overall costs of care, use of pediatric and adult PCP, young adults, we just talked about that a little bit. The no-show rates in, for instance, our internal medicine practice before the learning collaboratives was greater than 50% no-show rates for young adults. And the real crux of the outcome here is the visits with an adult PCP within 3 to 6 months. There's a lot of data that if there is connection and patient engagement, there are patient engagement tools if people are interested. They've been associated with levels and decreasing costs of care. They're very good patient engagement tools that you can use to measure patient engagement above the age of 18. Next. So I think the measurement and evaluations is in infancy. Using this clinical report as a conceptual framework in the 6 core elements has really made it possible for us to assess this transition process and consumer experience. We're in the business now of encouraging clinical, consumer, and payers to think about using these, looking at broader populations, involving all the stakeholders, consider utilizing the clinical report and the elements, and examination population health, consumer experience, and cost in follow-up. Next, I just have three slides quickly about the National Center to give you a sense of what we're doing. It's a cooperative agreement through 2018. Our job is really to do quality improvement. We've updated the 6 core elements, and I'll tell you who we're collaborating with nationally. We also do a lot of education and training. We do a lot around adult and family engagement and a policy. We're working on a bill in our Congress around this, and obviously information dissemination. Next. Gives you a picture of our website. We have multiple components. There's one for providers used in families and policy research and policymakers. Our young adult panel and families totally developed the youth and family FAQ component. And when you click on these, there are a lot of videos and so forth that many people have developed across the country and around the world, as well as there's a huge resource page. Next page, next slide. These are the folks that we're working with to start with across the Kaiser of Northern California. They're a completely self-contained payer, Health Partners of Minnesota, Henry Ford Health System, the Walter Reed Military. They're really focusing on specialty care. Cleveland Clinics around primary care, and the University of Rochester is doing subspecialty care. We're partnering with them. They're in the process of developing their evaluation approach and sort of coaching them across the process. Next slide. So we're also working with the American College of Physicians because the issue of the adult provider engagement, 22 subspecialties on the adult side have signed up to customize the 6 core elements for their particular diseases. And several U.S. states have really identified transition as what they're going to be looking at their Title V organizations. We're working with the American College Health Association around transition for those that are going into college. We have reports around starting a transition movement process, coding and reimbursement strategies, that's particularly U.S., as you can imagine, and incorporating transition into Epic EHRs. They own about 30% of the marketplace in the U.S. So I'm really finished. I think the next slide just is the end here. So I turn this over. I'm excited to hear your questions. This is really very an American approach to this. So, and I so appreciate all the work you're doing in Canada. It's very exciting.
Great. Thanks so much, Dr. White. Just a reminder to everybody online, if you have a question or comment, please type it into the question pane. And I just want to reach out to my other panelists and see if they're able to talk to me. Deb? Because I'm no longer hearing your voice. I used to hear it.
Yeah, it looks like to me that they don't have a microphone like I do when I'm looking.
Yeah, they're on the telephone though. They should be.
Yeah. So why does it? So I don't know why mine has a microphone.
Not quite sure what happened there. Let's just.
Can you unlock everybody and maybe they'll get unlocked?
Yeah, maybe we'll try. Mute. Oh, it's not letting me unmute people.
Can you hear us now, Lisa?
Yeah.
Oh,
hi.
But now I can't.
I'm here as well. It's Sandra. I don't know if you can hear me.
I can hear you now, Sandra. But now Dr. White seems to be permanently muted.
Oh, no.
So Dr. White, what I'm going to ask you to do is to put in an audio pin. If probably one was sent to you. And see if that will open the line for you. So just wondering, Deb, while we're waiting for Dr. White to come back, I apologize for all these technical difficulties. Deb, Gail, or Sandra, do you have any questions or comments?
It's Sandra Mish. I'd just like to say this was an excellent overview of transition practices, and it's very exciting what they're doing in the States. At Alberta Children's Hospital, we're looking at transition practices for neurosciences, and so this provides a lot of really good information for us, not just about with youth, but also thinking about that transfer of care and policy and involving youth and families in making policy on transition practices.
And it's Gail here at the Glen Rose Rehabilitation Hospital. I'm particularly interested in the population with developmental disability, specifically those with cognitive impairment and problems with executive function, making decisions and for themselves. And so I'd like to ask Dr. White, when she's back online, to see a little bit more about how this would be applied to that population. And I'm very envious about their high level of engagement with the adult system of care.
And this is Deb Thule. Is Dr. White back online yet?
No, not yet. We're working on it.
Okay. I think the thing that really stood out for me in the work that I do is the options for measuring transition implementation and quality improvement process. And so I've been working with the neuroscience team, Sandra's team, on the work they're doing. And so I think it gives clinics and clinical programs a really good way of measuring where they're at the beginning and actually measuring progress. And I think that would be very encouraging. And it also will help me from a program perspective measure uptake across the site. So you can use the tools in two ways. So I think it's some great work. And surprisingly enough, when I'm looking at the tools and the information that Dr. White has provided, it isn't, a lot of stuff that comes out of the States is very, very U.S. specific, but this is very transition specific. So I think is very applicable to program development and transition program development in particular in Canada.
We're still having issues. We're just trying some things in the background here. So Dr. White, another pin was sent to you. I don't know if it's a different one, but if you try entering that. maybe it'll work.
So did you try unmuting the rest of us again to see if she comes back online?
Yeah, I muted you all and then unmuted you, and yeah.
Oh no.
Sorry, this is terrible. This has actually never happened before. This is of all the sessions that I've ever. So I don't know. So I'm having this conversation with Dr. White. So the system told me that it sent you an audio pin, but it didn't tell me what the pin was. So I don't know. Maybe maybe Dr. White, I'm sorry to do this to you. Do you want to hang up your phone and then call back in? Like, don't disconnect from the computer, just hang up your phone line and dial back in. I'm sorry for all of this technical issue. So the number, if you click on the audio pane on your control panel, it should give you the number. It doesn't give me the number. Just a sec.
I can see it. Can she hear us?
Yeah. Can you just type the number into the chat line for her?
I will read it. It's 1-877-309-2074. And then the access code is 617-840-533. So it looks like she got that. She said, okay.
Yeah. Yeah, and I think there's different access codes that maybe for everybody has sort of a unique code. So we'll see what her should be in her email. Anyways, I think that from the community of practice perspective, there's certainly a lot that we can learn from this American model. There's always a few differences, but I think that the process is so similar and the challenges are the same whatever country you're in. So I think for the evaluation work, this seems really it's really going to be very helpful to us.
It's Gail here. I like the using the AIM framework. I think it simplifies a lot of the evaluation work when we get bogged down into so many measures and what are we after. But with doing the three focus components of the AIM with patient experience, quality of health care, and health expenditures, it makes it much more focused.
And I would agree with that, Gail. And I think it's really interesting that the article that did a review of the literature that Dr. White mentioned in her presentation called Measuring the Triple Aim in Transition Care. I mean, we're not doing that. Like, in really the research. If we all kind of, just chose to use the AIM framework in our research, I think we would probably be a lot further ahead. But it's amazing how, we're measuring very different things and, how, the work that needs to be done in that area.
And I think we get kind of stuck on numbers like number of patients who successfully land in an adult system of care, but we don't then reflect on the quality. Are they getting the services they want or need? And as a pediatric healthcare provider, am I supporting my adult colleagues sufficiently so that they feel more confident and equipped to deal with the population that I have become quite comfortable with because I've grown up with that individual from 0 to 18 years. So I think incorporating the AIM framework into our thinking will help us go back to that quality piece.
So are you there, Dr. White? I can sort of hear something. Oh.
Yeah. No, she said no go.
Yeah.
have any questions from our audience members to type in.
Yeah, there are. So maybe, Dr. White, sorry to do this to you, but I have one question here. So if the feedback from youth regarding their the youth provider is negative or critical, how do you handle this information? I don't know if you want to, if you're, you just click back to phone again, so I don't know if it resent you a pin, and try the pin again with the hash sign. But maybe just type in the answer to that into the chat box, and maybe we'll go this route. I really apologize.
Technology is amazing when it works, and when it doesn't, it can be very frustrating.
Yeah.
You know, I think using the AAA, I agree with what Gail has said about, you know, focusing, because then we can look at the quality experience for our patients, our families, the adult healthcare providers. But if we go with the AAA, it also gives us those numbers and that dollar saving that we're going to need to kind of impact, you know, the policymakers to say that this actually needs to happen, because we can actually, you know, from social determinants of health perspective and dollar savings, it's actually more economical.
So Dr. White says, if it is in the feedback survey, we send the results de-identified to the pediatric practice and they work to make an improvement.
That's an important point, is that communication loop back in as part of the continuous improvement cycle.
Yeah, so it's important. I mean, there's no sense in asking people questions if you don't do anything with the information, with the answer they give you. Another question about how do they keep the family physician involved? Ooh, goodness. Just gotta. So, Dr. White, I don't know if you have an easy answer for keeping the family physician involved.
That does seem to be something that we don't do so well. Once a pediatrician gets involved, the family physician really does get dropped out of the loop of communication, and then makes it really hard for them to kind of reassume the care when, you know, the young adult turns 18.
And I have another comment here. So thank you so much for the presentation. It was extremely informative. And I have a question regarding the transition of children with cognitive impairments or limitations to their ability to independently attend appointments.
It's Gail here. That was one of my questions and my dilemmas as well, because we want to respect the autonomy of that youth, young adult, but at the same time recognize that we need to continue to give them supports in the areas that they need that extra support, and whether it is having maybe not a parent at that point, but have somebody who is designated by the youth to be someone who accompanies them to appointments, or who ensures that the appointments are made. So a kind of a combination, as opposed to a straight independent, here you're on your own. So again, I think that's that flexibility in the transition process. We have a basic framework, but we have to make it flexible at an individual case-by-case level.
Does that sort of ring true to you as well, Dr. White? What Gail has just said, is that similar to? No, for the last question about keeping the family physician involved, Dr. White says she wasn't quite clear about what the questioner was asking, but the adult provider is usually the main provider with the pediatric and adult subspecialties as consultants. So she just wants to, Nancy, she just wants to know if she answered your question. Does that answer your question?
This may reflect a difference in the Canadian-U.S. Pediatric practices. In the States, pediatricians are considered consultant specialists. And in many areas of Canada, not all areas of Canada, pediatricians often assume primary care, right, from the well baby visits to immunizations and so on. And I think in terms of medical education, there is more and more emphasis on pediatricians becoming the consultant, and the primary health care providers then assume the ongoing care. But it's important that the pediatric consultant, whenever they do consult or see that patient, that there is a direct communication back to the primary health care provider to keep them into that loop, and to ensure that the pediatrician also says to the youth and family, you must touch base with your primary health care provider. I'm only dealing with this narrow piece of the problem that you've brought to me to address. So I think we've got a lot of, speaking as physicians, we've got to really look at how we practice to ensure that it supports transition.
Yeah, I would agree with Gail. I think that is one of the things that we tend to do a lot of the other care, other than what the specialty care provider might normally do, and so we sometimes as pediatric specialists become the main provider and leave the family physicians out of the loop. One of the things that our pediatricians are telling me is with the shortage of pediatricians, that's going to happen less as the population of people with chronic health conditions ages. So that might just help us, include the primary caregivers and the family physicians and keep them in the loop earlier on.
And providing the family physicians with, in their core training, the skills that they need to handle patients with complex needs, almost becoming, the repository of all the information on that particular child and family, and spending a lot of time with the child and family in integrating the information. And I don't have that opportunity within the medical school to actually know what their current curriculum is, but I think that might be one of the opportunities in the future to share what we've learned from developing our transition document with the primary health care providers who are educators in the medical schools to make that fundamental change.
So
I would agree, Gail.
Dr. White says this, in the U.S., the primary pediatrician gives preventative care, and many subspecialists do most of the care. So whoever has done most of the care will give support to the adult provider. If a family medicine provider is the main provider in the pediatric age range, and the youth moves away to another place, they would still be a consultant to the new adult provider, who could be an internist, a family provider, and adult subspecialist. With that,
I think that's another thing that stood out in the presentation, is that importance of the pediatric providers staying on as consultants for that period of 6 months. I think that is something that, again, we don't do really well, that we do the transfer of care, we send the paperwork over, and it's done. And the adult providers are not provided the support that they need. And I think Gail, also addressed the importance of being available.
yes. I'm just wondering, in light of the sort of the technical challenge that we're having, I don't know if we, it's up to everybody else online. I don't know if we maybe want to just end a few minutes early, and then we'll try to maybe bring Dr. White back to another one of our open discussions, and we can sort of continue the conversation.
That would be great, because we've got so much to learn from her.
Yeah.
Years of experience and her teamwork.
And I agree. I think one area that would be good to have a further discussion on is about the cognitive limitations.
Yeah.
And sort of the balancing of autonomy, helping support their development of self-awareness of their strengths and weaknesses so that they can guide their care as well. So as you were saying, Gail, is it that they are aware that they struggle in certain areas, such as memory, and so they designate someone to come to their appointment with them who could take notes or be able to provide information and review information with them afterwards so they don't forget that information. The other thing I think is really interesting about the transition readiness was specific to motivational interviewing, right, to look at sort of stage of change. And so not just what they can do, but what is important to them and how confident are they about their abilities, because I think that really does impact whether they're ready to proceed with a lot of these goals. And so you might need to be meeting with them at where they are in that stage of change.
There's actually not very much out in the literature around the ethics of transitions. As part of NeuroDevNet, I was involved with writing a paper on the ethics of transitions that was published in, I think it was 2013. But I think that's an area that does need exploring, that we need to provide youth with that kind of customized approach depending on what they need based on we need to be strengths-based, but there are also those limitations. We might want to invite an ethicist to the table at some point.
Yeah, I think that's a really interesting idea. So, and Dr. White had another comment about the whole about training. So in our medical school, we have the pediatric and internal medicine residents meet once a month to discuss pediatric onset diseases. So that's maybe a little different than what happens all the time. And she also says, in the U.S., we have legal guidelines so people can give decision support for those with intellectual challenges. So I guess that's similar to what happens here.
And that would be very similar for those who have an intellectual disability.
Yep.
However, it's sometimes a little bit more challenging for individuals who have cognitive limitations, even if they don't have low IQ.
Right.
And so to support them with decision-making, being aware of what their strengths and weaknesses so that they can advocate for themselves and really know what supports they might need when they do have some limitations.
Wow, can you hear me?
Yeah, you know what? I think that...
Oh my gosh, it just said unmuted. I don't know where it came from.
5 minutes.
Well, I'd be happy to be on another call. I'm not a very fast typist, so I have lots of things I could say. But you know, in our learning collaborative in the District of Columbia, we chose to work with our DC Medicaid. They're all on Social Security, which means 90% of them have cognitive challenges in this group, and we took on 400 of them. And the issues were to try and clarify the legal situation. And the managed care company does have a care sort of manager, but I don't want you to get too excited about that because they have 90 people to one care manager, you know, so there's not a lot of, but a lot of times they would come to the appointment or a family comes to the appointment. And when there's been, particularly, let's sort of get the transfer issues, this transition, which is the planning is over, but the actual transfer issues and how that looks varies very much with different subspecialties. So let's get some examples. So, for instance, in long-term follow-up of pediatric cancer, those don't go to adult oncologists in the U.S. system. They go to the general internist or family doctor with some clear guidelines. And in our District of Columbia, the people that live close, I mean, because the Children's Hospital is about a half hour away, they actually formed a separate clinic within the internal medicine department, and the coordinating nurse, because there's a lot more supports on the pediatric side in our system than there are in the adult side, comes over when that clinic happens, which is now happening 3 times a week. So she often comes over and sort of connects and be sure there's any issues that need to be handled. That similarly happens in the autism group. They have a lot more supports on the pediatric side, so we're trying to stretch those supports to help the adult providers early on when this process is happening. And also our geriatricians, who are very used to a lot of these issues around who can be and who can speak with and for the person, are really great people who have stepped up in some of these instances. Oh dear, I don't hear anybody.
Yeah, no, that's okay. I think we were all waiting for someone else to say something. That's kind of funny because we're all so happy that we're happy to be able to hear you. So are there any other final comments? We're coming to the end of our hour, unfortunately. Any final comments or questions?
I was just going to say in response to what Dr. White has just said, we seem to have a lot of similar challenges with, the transition, the resources on the pediatric side versus resources on adult side. And so I do think that there's much more that we can learn and kind of engage in the conversation. So, if you would be willing to come back to another time, that would be great.
Oh, you're very kind. I'd be happy to. I can learn so much from you all. I mean, none of this is perfect. It's all beginning to be worked out, and it's very, very local dependent, right? So, living in California in terms of supports and insurance and everything else is very different than living in Ohio or living in the District of Columbia, which isn't even a state. So it becomes very local issues and how these things are worked out, and availability and distances. And there's been a lot of work around, not doing face-to-face meetings, but as somebody transitions away from the Children's Hospital and is going to be seen locally, which may be, a day's drive away, there's been a lot of telecommunications, and often having a video conference occurs as this transition occurs. So there's been a lot of creativity trying to engage the pediatric provider to give all that information. There's so much pressure on that adult provider in that one visit to engage this youth. As an adult provider, I do with both peds and adult. If I can get anything that will make the connection, so I'm always asking the pediatric, what's special about this youth? I understand their medical issues, but are they an artist? Do they play soccer? What can I say when I first see them? Because I have to build a relationship in 2 or 3 visits that pediatric provider and team has built over 20 years. The pressure is so high on me that anything I can do, anything I can get that will help me make that connection and begin the engagement is crucial. And I think we don't do enough of that. I think we've been so focused on the sort of preparation and then sort of, the adult provider doesn't know enough. Well, of course they don't know enough. I don't know enough as an adult provider, but I need every support I can get. I want the family to be there only if there's been a very careful decision about how much they can be there. It's not that I don't want them there. There are just laws in the U.S. that are very clear about who can be there in terms of confidentiality and privacy, and I don't want to break those. I don't want to get in trouble here.
All righty, that's wonderful. So I think that we're going to end the session today, and with a big thank you to Dr. White. And yes, your name is Patience, and that was really important today. So I appreciate it.
Well, thank you. I really appreciated the opportunity.
And next time we'll just have an open conversation, I think, and none of this muting and unmuting business. But thank you to everybody, Gail, Deb, and Sandra, for helping as a panel, and to all of our attendees. Thank you for sticking out with us, and for all of your thoughtful questions and comments.